Assalamualaikum. Okay. All right. Have we got everyone? Okay. All right. Let's continue.
Okay. So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So, before that, let's start our session with Umum Kitab Al-Fatihah. So, I will continue our previous case-based seminar with the third topic, which is child with fitting. So, my name is Fatihah binti Syed, metric number 1813020. So, okay. So, fits in medical terms is known as seizure. It is a transient occurrence of sign and or symptoms resulting from abnormal, excessive, or synchronized neuronal activity in the brain. So, seizure itself, it is an event or a symptoms of a pathology.
Wait. Sorry. Seizure is not a medical term. Seizure is not a medical term. Seizure is an English term. Fits is an English. Fits is layman punya term. Seizure is a layman punya. It's an English term. It's not even a medical term. So if you're gonna say like a more medical or more Latinized version of it will be icteric. So it's like post-ictal, post-ictal drowsiness is that post-seizure. Kernicterus. So that's so seizure. It refers to seizure basically. So seizure is not a medical term, eh? I personally I don't like using word fitting. I prefer seizure. So if you present, I think it's better to say like presented with seizure on the, rather than presented with fitting on day of admission.
So seizure itself, it is a symptoms of a pathology. So it is not a disease. So while epilepsy, it is a disorder categorized by 2 or more unprovoked seizure occurring more than 24 hours apart. So epilepsy, it is a disease that is associated with spontaneously recurring seizure. So next is the classifications of seizure. So based on 2017 International League Against Epilepsy, so it can be classified into focal seizure, generalized seizure, unknown, and unclassified. So for focal seizure, it involves a focal area or a specific area in the brain, then it affects a specific portion of the body. So for focal seizure, it can be divided into 3, which is simple focal seizure, complex focal seizure, and also partial with secondary generalization. So for simple focal seizure, it is a seizure seizure that patient will have no loss of consciousness, and then they also can manifest with isolated motor symptoms such as Jacksonian, tonic, or clonic, and also they also can have isolated sensory manifestations such as paresthesia, visual, auditory, or gustatory hallucination, deja vu, or jamais vu. And for
What is deja vu? What is jamais vu?
Deja vu is patient will feels that that unfamiliar familiarity of the events, and jamais vu is the unfamiliarity of the event.
So it's opposite. So deja vu is a feeling of familiarity. You see something, say, hey, this is familiar, I've seen this. Sedangkan you tak pernah tengok. So that's deja vu. It can be normal as well. So jamais vu is a feeling of unfamiliarity for something that should be familiar. So you've already seen it, but the moment when you see it again, suddenly it becomes unfamiliar. Jamais vu ni banyak jadi time exam.
For complex focus seizure, it is a focus seizure that patient will have focus seizure with loss of consciousness. So and then it's also can before that patient before the seizure, patient can have aura, and then there will be a automatism, which is the repetitive behavior such as clamping of the teeth, smacking, licking of the lips, and also purposeful movement of the limbs. And it's for post-seizure, patient can have amnesia. And for the third is partial with secondary generalization. So this is a focus. Initially, patient will have focal seizure in onset, and then it spread throughout the cortex and causing the generalization. And next, for generalized seizure, so we have absent seizure, whether it is typical or atypical. So basically, for absent seizure is where patient will have loss of consciousness. However, there's no loss of body tone. And for
Dia sebenarnya kan, the actual pronunciation is bukan absent seizure, the absent seizure. So it's a French word. So absent seizure.
So next is generalized tonic-clonic. So for generalized tonic-clonic, it characterized as patient will have sudden loss of consciousness with tonic and clonic contraction, and it will precede it with aura. And then
there's another name for the absent seizure and generalized seizure.
For absent seizure, petit mal. For generalized tonic-clonic, grand mal.
Okay, again the pronunciation is actually petit mal. Dengan dia grand mal, dia bukan dia grand, dia grand.
Okay.
Grand Prix kan, Grand Prix. So ni grand mal.
Grand mal.
So it's French.
Okay. So for generalized tonic-clonic, so it also can associated with up-rolling eyeball and also cyanosis and so on. And patient also can have post-ictal phase where patient can experience sleepiness, headache, and drowsiness and so on. So other than that, for generalized seizure, can have tonic seizure, which is the generalized hypertonia or stiffness. Clonic seizure, where patient will have generalized shaking or jerking. And for my clonic seizure, patient will have a brief single jerking or single jerking. And for atonic seizure is when there's a sudden loss of posture, and for example, patient can suddenly fall to the ground. And for unknown seizure is unknown classification. For unknown, it is because it cannot be determined whether it is generalized or focal. For example, infantile spasm. And for unclassified, it is due to inadequate information. Okay, next. So next is for history taking. So so okay. Next is for causes of the seizure. So seizure, it can occur due to many very variety etiology. So for example, it can be due to CNS infection such as meningitis, encephalitis, and also brain abscess. Other than that, it also can occur due to CNS trauma such as acute trauma to the head, previous trauma that can lead to scar tissue formation, and also it can occur due to vascular causes such as infarction, hemorrhage, AV malformation, and also if there are any venous thrombosis. Other than that, it can be due to hypoxia, for example, hypoxic ischemic encephalopathy, and also can occur due to fever in febrile fits. And for other than that, it can due to metabolic causes such as hypoglycemia, electrolyte imbalance such as hyponatremia, and also due to inborn error of metabolism. And it also can occur due to neurologic effect of systemic disease such as sepsis. It also can due to toxic such as drug intoxication, for example, recreational drug such as cocaine, drug withdrawal, and also alcohol. It also can due to tumor, brain tumor, and also due to congenital CNS malformation such as cortical dysplasia or this encephaly, and also due to neurocutaneous syndrome such as tuberous sclerosis. And it also can be idiopathic. So next is for history taking. So for history taking, the first thing is we need to identify the witness for example, the parents and also the caregiver. So we need to have a detailed history about the pre-actal, actal, and also post-actal phase. So and the best is if there's a video recording about the event. So for the pre-actal phase, so we need to ask what patient was doing before the seizure, if there are any aura, or if there any history of fall or injury to the head, and also ask if there are any injection of drugs, and also history of feeding, and that might suggest hypoglycemia. And for interface, we need to know that how many episodes that occur at the onset, the durations of the seizure, the awareness level of the children, and also the nature and characteristic of seizure, whether it's tonic, clonic, or generalized tonic clonic. And if there are any associated symptoms such as uprolling highball, head deviations, rolling, teeth clenching, urinary or bowel incontinence, and what patient do during the events. And we also need to know if the termination of seizure it occurs spontaneously or with medication. For post-actal phase, we need to ask if there are any drowsiness, amnesia, or weakness. And we also need to classify to know whether it is a first episode or recurring episode. So for recurring episode, whether it is a known case of epilepsy, if the patient is prescribed with any medication, and the frequency of the seizure itself. And then other that, we need to rule out the head trauma and also the febrile seizure if there are any fever, any family history of febrile fit, infections, fever, if patient have photophobia, neck stiffness, headache, vomiting, rash, and irritability. And also for space occupying lesion, we need to ask if patient have projectile vomiting or headache. And then for other than that, we need to ask for past medical history if patient had diagnosed with meningitis before or had head trauma. Other than that, for the developmental history also important as delay in developmental developmental milestone may indicate a chronic causes such as due to congenital causes. And other than that, family history, if there are any family history of epilepsy, febrile fit, and also brain tumor, and also need to have history of drug that patient take. And next is for physical examination. So for general examination, we need to assess the GCS score, have the vital signs including the temperature, whether the patient is febrile or not, height, weight, and also head circumference. Look if there are any sign of head trauma, such bruises or bleeding over the head, signs of neurocutaneous disease, such as neurofibromatosis, such as cough outlet, meningococcal infections can have a purpurate rash, and if there are any sign of increased ICP. So patient can have for increased sign of increased ICP, patient can have bulging intraperitoneal papillary edema through we can assess through fundoscopy, and also hypertension and bradycardia. So we also need to perform neurologic examination. Look if there is a sustained head or eye deviation, any hemispatial neglect, focal myoclonus of the face or limbs, and also automatism. Not to forget to do Brzezinski test and also screening test if we have suspicious that this patient might have meningitis, as well as to assess the developmental milestone. Okay, next for investigation. So basically for investigation, it is based on depend on our history taken, also physical examination. What are our differential diagnosis? So but first we need to rule out the acute causes that can cause the seizure, such as hypoglycemia. So we need to take blood glucose level, and also blood glucose level, renal profile to look if there are any electrolyte imbalance, serum calcium, and also magnesium. Other than that, full blood count to look if there's any evidence of infection. INR and PTT, if we suspect that this is due to it might be due to intracranial, that patient have high risk of bleeding. So patient might have intracranial bleed and so on. Other than that, urine toxicology, if we suspect the seizure is due to drug toxications or withdrawal. And then if we suspect that this is due to meningitis, we need to perform a lumbar puncture. So for CT brain, it is indicated if we suspect the seizure occurred due to head trauma. And for MRI, usually for MRI, it is recommended. It is indicated if the child have persistent post-actal focal deficit or thought paralysis. And other than that, for EEG is usually recommended if patient have first febrile unfolded seizure. So next for management. So what we need to do if we encounter that a pediatric patient is having a seizure. So the first is for supportive management. So first we need to place the patient on a smooth space and remove if there are any harmful objects. Then loosen the tight clothes, especially over the neck, and then turn patient on the left lateral position. And also need to avoid placing any object in the mouth. And then we need to stay with the patient until he or she recover fully. And if the seizure is more than 5 minutes, so we need to give diazepam, whether it's IV or parenteral. And for post-seizure care, we need to position the patient in recovery position and maintain the airway. and then monitor and observe using the fit chart and also just this S chart, and also need to consider to have appropriate investigation throughout and to find the causes of the seizure. For example, the blood glucose level. So basically, for definitive management of the seizure, it is based on what is the causes of the seizure. For example, if it's meningitis, so you need to start antibiotic plus minus dexamethasone, and then we also need to perform a lumbar puncture and give a supportive treatment, such as if a patient has fever, so we give antipyretic. And for febrile, we just control the fever and give the antipyretic. And if the seizure is due to head trauma, we need to assess the ABC, stabilize the patient, and order urgent CT brain. And for epilepsy, we might need to consider the anti-epileptic drug therapy. But this AED, it is not indicated in all the seizure. So there's a few principles to start the AED therapy. So for anti-epileptic drugs, so first we need to classify the seizure, what is the type of seizure and epilepsy, because the drugs is based on the types and the syndrome, the epilepsy syndrome itself. And then the treatment recommended if there's more than 2 episodes, and it is as far as possible, it needs to be monotherapy. So we can increase the dose gradually until the seizure is controlled, or there's already maximum dose, or patient have manifest any side effect of the drug. And also we can add the second dose if this drug fail. However, we need to withdraw the first drug after the second drug. We have optimized the use of a second drug. And then we can also have a rational combination therapy, which is use 2 or maximum 3 drugs with different mechanism of action. And for withdrawal of the drug, usually after the patient have free of seizure for 2 years. So for this in protocols, we have the detailed list of how to the principles of anti-epileptic drugs. So you can refer that. So this the anti-epileptic drugs based on the epilepsy syndrome and also according to seizure types. So beside that, we also need to educate the parents what they need to do if their children having seizure. So what they need to do is they need to remain calm and not to be panic. So they also need to know time of the onset of seizure, and then loosen the child clothes, especially around the neck, and then place the child in a lateral position with the head lower than the body, because this is to avoid aspiration. And then what if there are any vomitus or secretion for the mouth. And parents also need to avoid insert of any object into mouth, and also do not give any fluids or drug orally. And then need to stay with the child until the seizure is over and comfort the child as she or he is recovering. So I think that's all from me. Thank you.
Status epilepticus, you're not talking about it. Management of status.
Tak ada tu.
Actually, that's a very important part of management of child with seizure. So if you talk about child with seizure, you should talk about status epilepticus, because if you go into exam, if you get case of seizure in exam, definitely we'll ask you about management of status epilepticus. how to classify, how to diagnose status, when do we diagnose as status epilepticus, and what's the management. So those are going to be part of exam question, because emergency management are very important. You need to know certain emergencies. Management of shock, management of status asthmaticus, management of status epilepticus. So these are things that you should know. So nanti just make sure you share to your friends. Well, it's in the PITS protocol lah. Actually, for PITS ni, if you hafal the PITS protocol pun, it's okay already. Tapi management of acute emergencies ni, you kena tahu. Okay, alright, boleh. So I expect status epilepticus. Okay. Any question from the group?
Doctor, I have a question.
Tanya presenter lo.
Alamak. Okay, I have a question. Do we give medication in order to prevent the recurrence of seizure, like retrodazepam? Practically, do we use?
Presenter.
If retrodazepam, usually we give retrodazepam if the seizure persists for 5 minutes, more than 5 minutes. So it is not to avoid like the next episode of the seizure.
Well, the answer should be it depends on the diagnosis. So if it's for example, if it's a known epilepsy, it's okay for you to supply retrodazepam for them to give at home as emergency punya treatment. But it's not useful for prevention. So retrodazepam has no role for prevention. It's used for acute management when the child is having seizure. 5 minutes is a bit long for me, but usually anything beyond 1 minute, I would actually give retrodazepam. But for epilepsy, known epilepsy, for febrile seizures, generally we do not need to give any type of treatment. Only control of the pyrexia, control the fever. But in some cases where the patient had frequent recurrent febrile seizures, we do supply retrodazepam for home. So kalau patient tu ada seizure at home, at least the parents can give. But we need lots of education lah. So we need to teach the parent when to use, how to use, what's the dosing, and so on and so forth. What's the complication of retrodazepam? So those kind of things we need to teach the parents. Okay, all right. Answered ke tak answered?
All right, answer, Doctor. Thank you.
Answered. Any other question? Tak ada? Okay, all right. Last presenter, last kan? Okay.
Izin. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I am Aina Haliti binti Hisham, matric number 1811106, and I will be the fourth presenter for this seminar. Okay, so the problem here is when a child with headache come to the to seek treatment. So okay, next. So basically, headache is, I'm sure everyone knows what headache is. Maybe everyone like have experienced it once in lifetime, maybe every day in their life. Okay, so headache is
lecturers usually headache during student presentation.
Okay. So headache is basically pain above the eyes and the ears, or above the orbital line. So for children who came with headache, it is usually rarely caused by serious underlying disorders. So it can be divided into primary and secondary headaches. Primary is usually caused by primary malfunction of the neuron and their networks. while secondary headache is the symptom of an underlying pathological condition. So primary headache can be divided into migraine, tension type headache, cluster headache, and also others. But the three above is the main. And then secondary headache can be due to various causes like medication overuse headache for like analgesics, head and neck trauma, vascular malformation, intracranial hemorrhage, raised ICP, and then alcohol abuse, drug abuse, infection, meningitis, encephalitis, abscess, hypertension, hypercapnia, acute sinusitis, or also emotional disorders. Next. Okay, so I will move on to the primary headache. Primary headache, like I mentioned, tension type headache, migraine, cluster headache. For migraine, we have migraine with aura and without aura. But for children, usually they came, 90% of them are usually migraine with the aura. Okay, so for tension type headache, the site is usually at the frontal. It occurs bilaterally at the front. And then the frequency is, it occurs almost daily and very frequent, and it has gradual onset of pain. For characteristic of pain, it is non-throbbing in nature and the intensity is mild. It is aggravated by stress and skipping meals, and the duration is usually from 30 minutes to up to 1 week duration. Symptoms are usually lightheadedness and also fatigue. For migraine, it is usually at the frontal and temporal area and bilaterally. It usually occurs once to twice per month, and the pain is pulsatile and throbbing. It is focal, and the intensity is moderate to severe. It is aggravated by physical activities and usually relieved by sleep. Okay, the duration can be 2 hours up to 3 days, and the associated symptoms are usually nausea, vomiting, photophobia, and phonophobia. Phonophobia is sensitivity to sounds. For next one is cluster headache. Cluster headache is usually unilateral and occurs at the periorbital area. The frequency is 1 every other day, means like today and then selang sehari. And then this is from the diagnostic criteria, 8 per day for more than half of the time, which means that if the headache is for 1 month, and then 15 days, the headache occurs 8 times per day. I think this sharp and stable in nature, it is very severe. For aggravating factors, is usually can occur from 15 minutes to up to 3 hours. The associated symptoms are conjunctival injection, nasal congestion, edema of the eyelid, and also sweating of the face. Okay, next.
Ni dapat mana ni ya?
From the diagnostic criteria from the IC International Classification
Okay, alright.
of headache. Okay. So next slide, please. Okay. So secondary headache. Usually by increase in intracranial pressure, for example, like brain tumors or space occupying lesion. The clinical features usually is the headache is worse when lying down. The patient might have morning vomiting, nighttime waking, changes, visual field defects, and cranial nerve abnormalities such as squint. Squint is also known as strabismus, which is diplopia, facial nerve palsy, abnormal gait, head tilting or torticollis, growth failure and development, and also papillar edema, cranial break, and also early or late puberty. Okay, so next. So for the history taking, for the history of present illness, the chief complaint is headache. So we should ask to exclude any migraine with aura. The characteristic of the pain, the the site of the is there any radiation to any area, the frequency of the pain, the duration of the headache, any trigger of the headache like stress, food, menstruation, any relieving and exacerbating factors of the headache. So we should also ask if there is any emotion of child, especially at home or at school, or the patient have any maybe he or she didn't wear specs and they have headache, so we should get their vision checked. If there is any recent head trauma, any alcohol substance abuse, and any anesthesia overuse to rule out any medication use headache. We should also ask if there is any significant medication history, and also if there is any of brain, and also the developmental history to know if there is any developmental delay which is significant for this condition. Next. Okay, so when asking for history, we should watch out for the red flag symptoms. Basically, red flag red flag signs and symptoms refers to the secondary headache, which like meningitis, or increased intracranial pressure basically. And so headache for red flag symptoms, it is headache that is first when lying down or with coughing and straining, headache that wakes up the child, headache that is associated with confusion, morning nausea and vomiting, and also changes in the personality and behavior. Next. Okay, so for the physical examination, from the general appearance of the patient, if the patient has raised intracranial pressure, they might have altered mental status, also have abdominal gait, skin rashes or lesions like cafe ole in neurofibromatosis, signs of head and neck trauma. And then for vital signs, the patient might have fever because of infection, like meningitis, high BP because of hypertension. Hypertension can cause headache. And then upon fundoscopy examination, we can see if there is a raised ICP, we can see if there is papillary edema, like in the picture below. And then neurologic examination, we can see if there's any ataxia, and also if we do cranial nerve examination, maybe they have facial nerve palsy. Okay, next. So this is for the red flag signs for the increased intracranial pressure. If there is any growth failure, there is any squinting in the picture above, and then any cranial nerve abnormality, torticollis in the picture below. It is head tilting, abnormal coordination, especially if there is any cerebral lesions, any abnormal gait for upper motor neuron lesions, fundus and fundoscopy, we can see papillary edema, bradycardia, and also cranial bleed that can that can indicate AV malformation. Okay, next. Basically, for investigation, for patient who came with headache, it is usually not indicated if there is any if there is no red flag features. But if we suspect the patient, for example, have meningitis, because the three signs of meningitis is photophobia, neck stiffness, and also headache. So we can do laboratory investigation such as lumbar puncture and full blood count. And also if we suspect any substance abuse, we can do serum or urine toxicology. So for neuroimaging, like MRI and CT scan, it is indicated only when there is abnormal neurological examination, the patient is younger than 6 years old, and the patient has very severe headache with an underlying disease that can predispose to intracranial pathology. For example, the patient has young hypertension, so maybe we suspect the patient have any intracranial pathology that causes the headache. So severe headache, usually like they said that the headache is the worst headache in their life. So we should suspect that there might be some abnormalities. Next. So this is the diagnostic criteria for primary headache, which is common. This is basically quite similar to the table I've presented before from the ICHD international classification of headache disorders. Okay, next. Okay, the last part of my presentation is the management. Management for headache can be divided into pharmacological and non-pharmacological. So for pharmacological treatment, we can, for acute headache, we can give analgesia like paracetamol and NSAID. And for if the patient has any vomiting, we can give antiemetics like prochlorperazine or cyclizine. If the patient have migraine, we can give anti-migraine such as triptopans, namely like sumatriptan. And for traditional treatment, we can give cold compressors, warm pads, or topical for head burns. For prophylactic treatment, especially in children who came with frequent headache, we can give sodium blockers, beta blockers, cyclics, or do acupuncture. Okay. Next. Okay, so for non-pharmacological treatment, we should give psychosocial support, especially when the patient came with headache due to emotional stress. So we should give psychological support, ensure the patient has good relaxation and self-regulating techniques, ensure the patient has good and regular rest, play, basically having a balanced and healthy lifestyle to prevent any future headache. Yeah, okay. Next. Okay, I think that's all from us.
Okay. Any questions from the group? Ada? Ada? That the picture clearly depicts the condition of everyone is in, including me. Okay. Okay. Tak ada question? Tak ada? Last kan? Ada lagi? Okay. We have another session with the whole group kan malam ni?
Yes, Director.
Pukul berapa
Pukul 8.
Pukul 8 Okay. Alright. Right. So we'll see you tonight at 8 PM. Okay. Assalamualaikum.
Assalamualaikum. Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you.
Thank you, Doctor.